Well, thank you again. I decided one example of the ablation in liver cancer, in primary cancer, HCC, and colorectal liver mets. We have a different ablation therapy with heat and radiofrequency is the most common, or more history, but at this moment less than 10% of a patient we treat with radiofrequency. Microwave at this moment is the most important ablation therapy. Laser for a study. HIFU in liver really is only for research, and the cryo is more useful is cold, useful in kidney and not in liver, only in some Japanese and South Korean center. And the electrical pulses is not heat or cold, is irreversible electrophoration. We have the possibility to use different approaches, percutaneous, laparotomic, laparoscopic, or endoscopic ultrasound. At this moment, it's possible more use laparoscopic or laparotomic, but in the near future, the percutaneous and endoscopic ultrasound, in our opinion, is more and more frequently to use to treat the liver tumor. What is the rationality of use ablation in hepatocarcinoma? Well, in this paper is very clear. With this, we have the possibility to, in ACC tumor less than 3 centimeters, the possibility to the microsatellite tumor is very unusual, and the more to 3 centimeters is very common. For that reason, the use of ablation therapy, because with the idea of the ablation only the tumor and not treat the microsatellite tumor is possible. In colorectal mets, the rationality of use of ablation is, well, I use this paper of the HPV surgeons about the tumor biology is the most important predictor for intrahepatic recurrences and survival, rather than the amount of millimeters of negative resection margin. And these authors, surgical author, and talk about the surgery, is a complete tumor removal when the unnecessary sacrifice of functional parenchyma has been associated with best surgical result. Well, the idea is what is the best option of a treat one tumor without not remove the unnecessary functional parenchyma is the ablation therapy. Of course, the new surgical technique and the new images and the possibility to use new probes in this patient, plus the possibility to use more than in the same moment more than one needle or one antenna for the treat this tumor, has the possibility to use more and more with better result this ablation therapy. For us, the secret of the treatment of the ablation therapy now and in the near future is the innovative vision with CT and ultrasound. The first step is the diagnosis and planning. We use the diagnosis more and more diffusion MRI, but the problem is too complicated to use MRI for treat these patients, and they use the augmented reality to the planning these procedures. Later, the localization of the target is very important thing, and we use more and more fusion of images to the CT plus ultrasound or MRI plus ultrasound. Secondary, well, the choice of ablation system is impossible to use only one machine. I said we use radiofrequency for all patients or microwave for all patients. It's necessary choice of ablation system. The third step is the placement needle. For that reason, we use more and more electromagnetic and optic or optic guidance. And in the future, our idea is use more robotic and artificial intelligence. And the last step is the control of a result. At this moment, the control of a result is necessary more than 1 month for the edema, etc. But we study at this moment in Strasbourg, in IHU, different possibilities to the immediate control of result. And we use a lot of things, but in our opinion, as a future paper, is the ultrasound elastography is the best option for the immediate control of result and decide the continuous or not in the same moment with the ablation therapy. Step by step, diagnosis and planning. The idea of planning with augmented reality is a lot of paper about this of Luc Soler, Michele Diana, and Jacques Marescot about this. We had the possibility to say, well, in this patient with this target, the best option with the relationship with the vessel of the bile duct, we use this machine and we use this access. The planning is essential for the result of with ablation therapy. Localization of a target. Well, we use at this moment, we have different possibility. This is a calcination system. It's an optic navigation system with a possibility to mark the target and said, well, in the needle is the better approach is for this this location, etc. Of course, we use for the localization of a target not only the other possibilities. We use more and more augmented reality. This is a live case, and we use the augmented reality in Strasbourg in the hybrid surgical room. And we have the possibility with augmented reality. We use the ultrasound or ultrasound with a fusion of images, plus in the same moment augmented reality. And we have it's very simple to say, well, this vessel is the hepatic vein or the cava vein, etc., because it's possible view in the same moment augmented reality and classic ultrasound. Choice the ablation system. Well, at this moment in the liver, a lot of several centers around the world use these three first: radiofrequency, microwave, and irreversible electroporation. In our opinion, in a small tumor less than 2.5 centimeters, it's possible radiofrequency ablation is a good option because it's a good result in very small tumor with very less complication. The complication is lower than microwave. In tumor more than 2 or 2.5 centimeters, microwave is better. And in tumor near the structure, especially to the biliary structure, the irreversible electroporation will be the best option of treatment. The placement needle, well, we have a possibility to use a lot of things, or the navigation system, optic or electromagnetic, and this is one very interesting, and of course fusion of images. This is a very interesting paper performed by one of our fellow in IHU, the Federico Dabria, and show for the another fellow, Christian Gonzalez, yesterday here in the SAGES, about the use of the first line. The blue line is the classic, in the beginner and expert, the classic ultrasound and a needle. And in the second line is the result to the accuracy of the beginner and the expert with electromagnetic guidance. Well, it's very funny because with the beginner, with this electromagnetic navigation system, the result is similar with the expert with the classic procedures. But for us, for the expert, it's a good thing. The use with this machine is the better result to the expert too. But is in case of this result, it's not only to the phantoms. It's possible to use in human with the breath, etc. And the result is this result. Well, it's possible in a few years will be forbidden use the classic procedures, and we need the navigation system in all of our cases. We have the place needle. Well, we have this is the optic system, and it's more important, for example, in case of we use irreversible electrophoration, because we need more than one needle. We need 2, 3, 4, or 6 needle, and with the exact position for the result. Really, the irreversible electrophoration is a very good ablation system, but it's too complicated to use, and the use of this optic or electromagnetic, for example, this is for microwave, is the Medtronic machine, really is a good thing to work. We work with all of this, and all said it's a good thing, but is the evolution. We need, in my opinion, 2 or 3 years more to obtain the last navigation system, the best navigation systems. The immediate control of result, well, we use this possibility to use a laparoscopic approach or an elastography, and we use a lot of things. We use immediately MRI, elastography by MRI, CT, ultrasound, Doppler, and elastography, and the combination of elastography plus Doppler, in our opinion, is the best result. For example, in this patient with a radiofrequency ablation with the vessels, and it's possible view the result with the elastography is not totally good, and we need more ablation. And really, in this case, we change to microwave. Finally, the result with this ablation therapy, well, I prefer use a surgical paper and not radiological or interventional papers. And this paper from MD Anderson, or from Claudio Conrad and Nick Botte, said, well, in patients with HCC tumor less than 3 centimeters, of course, the transplant is the best option of treatment, but radiofrequency or surgery has the same result. But in patients with more than 30 millimeters, 3 centimeters, with 3 to 5, the result is better with surgery. But in more than 3 centimeters, 3.5 centimeters, is better the surgery. Why? Because the microsatellite tumor with a patient with more than 3 centimeters ACC. And in the colorectal mets, in this interesting paper of the different very famous French HPV surgeons, said, well, the use of radiofrequency plus hepatectomy has the same result to hepatectomy alone in specific patients with a long follow-up. For that reason, our algorithm at this moment is in liver tumor, ACC or colorectal mets less than 3 centimeters. In the peripheral tumor, we prefer use laparoscopic and laparoscopic ultrasound. We have the 2 possibilities. One is the resection, laparoscopic resection, or ablation. In tumor less than 2 centimeters radiofrequency, in patients with more than 2 centimeters, microwave is quicker and very easy. And in patients with intrahepatic tumor, we use not laparoscopic, we use a percutaneous and CT ultrasound fusion plus navigation system. In patients with near main bile duct or major vein, the irreversible electrophoration is possibly the best option of treatment, the most safe option of treatment. And in any other localization, we have the possibility to use in less than 2 centimeters radiofrequency and more than 2 or 2.5 centimeters microwave. Of course, in case of tumor less than 2 centimeters but close to the vein, we have the possibility to use microwave, or in a specific patient, we use the irreversible electrophoration. This is our point of view. Finally, we have the possibility to use this technique and new techniques. We use, for example, in the Alps, it's a very good technique, but with not good results. For that reason, we use a percutaneous in our study in animals at this moment. We use the percutaneous portal vein embolization, and this pig for the left side. Secondary, the first step of the Alps was not surgical, was a percutaneous, and we cut the liver with a percutaneous access. Use images. This is a cut of the liver with a percutaneous access without surgery. We wait 5 days, and later we increase the right segment in this case, and with laparoscopic access we perform the second step of the surgery with a laparoscopic resection. And this is a very interesting thing because the inflammatory of local inflammatory and general inflammatory is very, very, very low, and we think is very interesting procedures. Of course, well, we compare. This is a classic portal vein embolization in this lobe. Is better, or is different, but it's not totally different. And this is with the PRALPS procedures, one side and another side. Finally, today, however, surgical resection is better, but in our opinion, in a few years, it's possible less than 5 years, better images and better and the diversity of ablation system change this, and the gold standard will be ablation and not resection in tumor less than 3 centimeters in the liver. Thank you very much.